Hi, and welcome to the Future of Dermatology Podcast. I'm your host, Dr. Faranak Kamangar, board-certified dermatologist. We are here to talk about anything and everything dermatology related. You'll hear from me and my guests who are dermatologists, physicians, experts, scientists, residents, and medical students in the field of dermatology. We publish weekly, so if you like what you hear, hit that subscribe button and show us some love, and thank you for joining us.
We are back for our Dermatometabolic series. So today we're talking about incretin medications. These are well known as your GLP-1 agonists. But the incretin medications include not only the GLP mechanism, but also what we call the twin incretins, which has the GLP and the GIPs. And then there's new medications coming out called the triple Gs that are going to include GLPs, GIPs, and also glucagon. So let's get into it. I have some slides up too, but if you're listening to this on the podcast platforms, which most people, that's how they listen to the Future of Dermatology podcast, you definitely don't need the slides. I will describe what's on them, but if you want to take a peek at them, the slide version will be on our YouTube. So I have a slide up, and it is a slide from a prior talk that we had on this podcast. And this talk was about how dermatology and aesthetic medicine is changing from the traditional, fill someone's face up with filler. And there's a photo on this slide of Kylie Jenner. There's one before she had her work done and one from after, showing how we just kind of fill up the face, make the ratios perfect, chase this Fibonacci ratio of perfect facial structures to now we're turning more internal, and aesthetics is moving towards a more longevity and then anti-aging from kind of an internal source. So on the same page, there is a picture of the Krebs cycle or the citric acid cycle. This is basically your inner core engine, your metabolism in every cell of your body. And here lies the secrets of where we are going with longevity medicine to make your metabolism and energy as healthy as it can be. So this slide, from a prior talk that we gave, we kind of joked, well, what's sexier than Kylie Jenner? And the new sexy thing is the Krebs cycle. But I have another following slide, which I'm showing the next thing sexier than Kylie Jenner, and it's Scott Disick. And he is one of the other Kardashian clan. I have his picture up. It's the one where he looks very gaunt, and you could see hollowing in his temples and his cheeks. This is during his Ozempic phase, or presumed Ozempic phase. And the public thought he was taking these medications, the GLP-1s, was having that classic face. He may at some point even, he may have denied it and said that he wasn't on it. And then the other photo is one of him on the show with Khloe Kardashian, opening up his refrigerator. And there is the box of Mounjaro. So his secret is out. But I guess he wasn't really lying, because he was on Mounjaro or Terzepatide, which is a dual GLP and GIP. And he was not on Ozempic, which is Semaglutide, which is a GLP agonist. So that is a head start to what we're going to be talking about today, which are these GLP, GIP medications. And we want to tie it back to why it's important that we know about them as dermatologists. So the incretin medications, even though we're talking about celebrities, and the celebrities have made these medications really hot and really trendy right now, incretins have been around forever. So in 1932, the term incretin was first used for gut hormones that stimulate insulin secretion. So the celebrities didn't just create this as a recent. In the 1970s, GIP was identified. And then 2005, the first GLP agonist, exenatide, was approved for type 2 diabetes. So these medications have been around for a really long time. They've been around since 2005. We have a long history of safety profile on the GLPs. So a lot of people will say, well, these are new and let's see what happens with them. But there is this they've been around for a pretty long time. We have a lot of data on them. 2017 to 2023, more came out. So semaglutide, tirzepatide, and then more importantly, the indication for weight loss was added, which is what's made them so hot and trendy and on topic right now. So understanding the GLPs, they're medications that mimic the native GLP in our gut. And they're 90 to 94% homologous to the native GLP. And they regulate our appetite and our sugar glucose homeostasis and metabolism. The interesting thing is that the GLPs are acting on multiple targets. They act on the CNS, right? Your brain and the hypothalamus to increase satiety. These are some of the interesting parts of this because, of course, acting on the gut, slowing gut motility, that was known. But what we're finding out is that they actually have effects on your brain centers, which is incredible. And there's been this extension out into what about other addictions and other broad uses of these medications? They also act on pancreas to upregulate insulin. And then more importantly for us in dermatology, they have anti-inflammatory effects, which is very interesting to us because we see a lot of inflammatory skin disease. And we know that a lot of our inflammatory skin disease have the correlation with metabolic syndrome. So in our other talk from this series, we talked about psoriasis, hidradenitis suppurativa, among many of our conditions that we now have this metabolic syndrome basis. So let's talk about semaglutide or Ozempic or Wegovy are the names for it. So you start at 0.25 mg weekly, and then you go up very slowly, right? So you don't want a whole lot of weight loss to happen all at once. B1, because you're going to get a lot of side effects. You're going to get nausea, diarrhea, abdominal pain if you're, really high dose. So you got to start slow, go up slowly. If you have rapid weight loss, you can get gallstones, which you don't want. Worse than gallstones, you could get either Ozempic face or Ozempic butt. And that's if you're trying to lose weight, you want like maximum of 2 pounds per week. Any more than that, and people run into trouble. And then you can increase it monthly. Eventually, you might get to a maximum dose of 2.4 milligrams weekly. A popular trend, though, is to stay at 0.25 mg, what's called microdosing, which a lot of people who, if you're using it for obesity, like real, true obesity, the medical indication, then you likely will titrate up if you tolerate it and side effects allow it to go to your full dose so you can lose as much weight as you need to come get to a healthy weight. For people who are using this to lose a few pounds, they're microdosing. I don't recommend using this to lose a few pounds. We'll get to that. But that kind of has a slower weight loss to it and an attempt to avoid the unexpected or unwanted effects of having facial hollowing and loss of your subcutaneous fat in your face. One thing to note is these were diabetes medications, if you remember. So you can get hypoglycemia or low sugars after exercising. Pancreatitis is an uncommon side effect, but pretty serious, but luckily it's pretty uncommon. And then in lab animals, in rats, an increased risk of thyroid cancer was noted, but important, not in humans. And these medicines have been around for a long time. That's not like they just came out. So probably an unlikely risk. But again, on the package insert, it says to avoid if you have a personal or family history of medullary thyroid cancer or MEN2 syndrome. And you can get telogen effluvium. That's that rapid kind of hair shedding that you can get. That's not specific to these medicines. That can happen with any weight loss of any kind. But one caveat to this, I would say, a lot of our hair patients are very nervous about losing hair. So if you have a tendency to lose hair, you don't want to go on anything that's going to cause more hair loss. But I would say, telogen effluvium is acute. It's short-lived. It's going to help. And in the long term, like we talked about in our other talk, these types of medicines, if you're able to get your metabolism healthy with these medications, you can actually treat some elements of androgenetic alopecia or hormonally related alopecia and also possibly scarring alopecia. So in the long run, it's probably a good thing for your hair to get your metabolism right. If you lower sugar too quickly, there's a risk of diabetic retinopathy. Of course, fatigue, headache, and rash has been seen with the GLPs. So the side effects, like we talked about, ways to mitigate it: eat smaller portions, stop eating before you feel full, avoid fried, greasy, oily foods, and stay really, really hydrated. And usually with slow titration, these symptoms improve within 4 to 6 weeks. to the point where most people tolerate the GLPs. Having said that, the studies show that a lot of people actually stop these medications after about a year. So possibly the side effects don't fully go away. Let's take a look at how well semaglutide works. So this is the step 1 trial, or the pivotal trials, and looking at different levels of weight loss. So you have categories of people who were able to lose at least 5% of their body weight, at least 15%, and different degrees. So let's take a peek at semaglutide versus placebo. So people that were being followed in a clinical trial setting, but not on medication, the placebo group. So for the category of weight reduction of at least 5%, 86% of people in the semaglutide group were able to achieve this. So that's a pretty high number, 86%. 86% were at least losing 5% of the body weight. That's versus 32% of the placebo group. Now let's take a look at weight reduction of at least 15%. So that's a much larger area of extent of weight loss. So for weight reductions of at least 15%, 51% of participants in the semaglutide group achieved that versus only 5% of people in the placebo group. So, losing a little bit of weight is doable, right? 32% of placebo group in the 5% weight loss group. But when you're talking about extensive weight loss, like 15% or above, only 5% in the placebo group achieved that. It's hard, even in a clinical setting where you are being followed over time and you're conscious about your weight. It's tough to lose weight. That's why these medicines are helpful. Let's take a peek at semaglutide versus liraglutide, which was a GLP that came before semaglutide. Liraglutide is 3 milligrams daily. Semaglutide was in this trial was looked at with 2.4 milligrams weekly, which is the full dose of semaglutide. And the comparison between the two showed that there was significantly greater weight loss with semaglutide. So if you're going to look at semaglutide versus liraglutide, semaglutide seems to win. That's Ozempic or Wegovy. The next slide is really showing that these are chronic medications. So this is the step 4 randomized clinical trial looking at semaglutide versus placebo. And an interesting thing is that in the beginning, you're looking at everybody in the semaglutide group, and they are losing weight as expected. About 20 weeks in, they split the groups up into people who are no longer going to get semaglutide and people who are going to continue semaglutide. I wonder what the people that got randomized to not taking it felt. They're like, darn it, I don't get the magic pill or magic injection. But so they split them into 2 groups. And the interesting thing is, of course, the people that are continuing semaglutide, they're continuing to lose weight, as we would expect. The placebo group, though, because some of the thought is, well, if you're able to, help jumpstart weight loss, even if you stop it, you're going to have instilled all these other magical things to keep the weight off. And that's in reality not true. So the people on semaglutide who stopped taking semaglutide, the weight came right back. So really, this is probably out of everything the most important point. If you're going to start these kinds of treatments for weight loss and you're not adding anything else in, like lifestyle modifications, exercise, food, diet, if you're not adding any of the other stuff, if your only intervention is this medication, that kind of means you're buying yourself a lifetime of being on this medication. Otherwise, if you're not committing yourself to chronic use of this medication, I wouldn't start it, necessarily for weight loss. On the other hand, it's fine to be on these medications, long term. I mean, we're kind of used to that in dermatology. We put a lot of our psoriasis, atopic derm patients on chronic therapy because we know these are chronic conditions. Obesity is similarly a chronic condition. There are lifestyle factors that can help, but they're really hard to instill and keep up. So that's a really important factor here. If you're in the subgroup where you're trying to lose a few pounds, this is not a good way to go. Because if you go on these medications, you're going to lose weight, specifically on semaglutide, as we'll get to, Ozempic or Wegovy. You're going to lose a lot of muscle weight too. Your muscle is your baseline metabolism. So when you stop, you're going to put weight back on in the form of fat. So your body composition is going to end up being more fat than muscle. All you've done is you have the same weight now, but you've decreased your metabolism. You've gotten yourself in a hole. So really important to know how these medicines work before just taking them. Monitoring, there's no lab monitoring. This at home, patients should be following their weight weekly to make sure they're not losing too much weight. And if they're on blood pressure medicines, they should check their blood pressures weekly as well. Let's take a look at Terzepatide. This is Mounjaro or Zepbound. Terzepatide is a twin incretin, so it has two ingredients, right? It acts uniquely on both GLP-1, glucagon-like peptide 1, and GIP, glucose-dependent insulinotropic polypeptide receptors. And it's thought that combining two elements kind of balances things out a little bit better. So you're potentially offering a better metabolic control and you have fewer side effects. Terzepatide starts with 2.5 milligrams weekly and can go up to 15 milligrams if needed. And this is important, there's decreased muscle loss as compared with Semaglutide or Ozempic. That's a great thing. So the SURMOUNT-1 clinical trial is their pivotal trial. In this trial, patients experienced a 33.9 reduction in fat mass and a 10.9% reduction in lean mass, which is muscle. So that means less than 25% of the weight that they lost was muscle. So less than a quarter, meaning majority of the weight they lost was fat. Step 1 of the semaglutide trial, if you remember, 45% of the total weight loss was lean mass or muscle, right? So with Ozempic or semaglutide, it was almost like half, like, almost half muscle, half fat. And with Terzepatide, you're losing, about 3/4 fat, less than a quarter of muscle. That's really key because when we talked about your muscle is your metabolism. The more muscle you lose, you're going to just decrease your metabolism, your work engine of your body. So GLP-1 agonists versus the dual GLP-GIP. The mechanisms thought for this muscle preservation is that GIP stimulates insulin secretion. Insulin is actually a powerful anabolic hormone. So with these GLPs, we're causing a lot of catabolic events to happen, right? Breakdown of fat, breakdown of muscle. It's good to have a hormone in there that's also stimulating some anabolic hormone, right? So you're able to also build while you're breaking down. So insulin promotes protein synthesis in the muscle and inhibits protein breakdown. Those are all good things. And this counters the potentially catabolic effects, like we talked about, because otherwise you're just having significant caloric restriction. You're having just less calories come into your body. So your body is just going to break everything down in its path to try to create energy for you to survive. But if you have some anabolic hormones in the mix, you can keep up your muscle mass. And some research shows, although this is minimal, that GIP receptors might even be present in the muscle tissue themselves. So there might be some direct effect there. And then by having more hormones, you can have more of a balance. So it's thought GLP plus GIP is a better thing because you have a little bit of kind of a balance there. We'll see what the triple Gs do because you're going to add glucagon in there, and we'll see how that turns out. So let's get to Ozempic face. So what is going on? What is the big deal with Ozempic face, right? And it's unfortunate that Ozempic gets this title because really all these medications could cause this. What's happening is rapid weight loss. If you have rapid weight loss and pretty effective weight loss, that's the other thing. I don't think anything else before this has been that good at weight loss. And also the other drastic measures for weight loss, let's say like bariatric surgery, usually was done in patients who met the criteria of obesity. We haven't had a situation where non-obese individuals who wouldn't qualify for bariatric surgery are getting treatments that are just as effective as losing weight. So no one's basically been able to lose weight this much, this fast, often before these medications. So what we're really seeing is just really effective weight loss, really effective caloric restriction. What's happening is that, you have these fat pads in your face. You have these deep fat pads, and then you have this subcutaneous fat right underneath your skin. As you age, you naturally are going to lose those deep fat pads. But what's thought to happen with this Ozempic phase is you're actually getting a decrease in that subcutaneous fat layer that's right underneath the skin. And that is giving you this hollowing in your temples and your cheekbone and around the eyes. I think is the most significant, that kind of look that makes you look just like super tired and super old. So I have a slide up here that's showing ways you can restore some of that volume with biostimulators, with hyaluronic acid. You can get in there with radiofrequency microneedling and get the skin to form more collagen. And that includes lax skin elsewhere from weight loss, and then autologous fat transfer. I have all of these metrics here. We could do all of these in the dermatology clinic. And actually, the aesthetic market is really up because of this specific issue that needs to be fixed. But I'm going to say something that's a little bit maybe counter, maybe not as popular. And I would say if you've lost enough weight where you've lost everywhere, and now you're losing the fat underneath the subcutaneous layer of your skin, maybe you've lost too much weight. My unpopular here and recommendation is slow down your medications, increase your calories, maybe put on a little bit of weight. Because usually this is not like a first thing to go, right? These are kind of last step fat areas of fat. It means you've lost so much weight elsewhere effectively that you're really, you're going down to the bone to get an energy source. So I would say that's probably a little bit, you want to balance. You don't want to just keep going just to keep going. More of a good thing is not necessarily better. So I would say slow down the weight loss, put on a few pounds, get the facial fat that you have naturally to come back, especially if you're young and you're really losing this fat because of these medications. Get that fat back, because that fat can do things that external biostimulators and hyaluronic acid can't do. Your own fat cells have stem cells in them that you need. So get back your own facial structures. That's my advice there. And then some people will keep going because they have fat, kind of hot spots. Let's say they're like, well, I've lost weight, but I want my abdomen to be fully flat. Let's say, for example, or my love handles. And they're scared if they put on a little bit of weight that those little hot spots are going to come back. But I would say we have enough good body contouring devices now. There are many and they're very effective. I would say put the weight back in your face, your own natural weight. And for the body, for those hot spots that you're trying to get, use the body contouring devices. So if you're going to be spending the money on hyaluronic acid, biostimulatory agents for your face, save that money, put on a few pounds, and spend that money on body contouring devices. They're non-invasive. There's many of them out there. Spend that money on those hot spots. That would be my recommendation there, because that facial fat that you have that's naturally there is gold. I mean, literally, it is gold. It has stem cells, has all the things that you need. The skin overlying it needs those items to stay young and youthful. And we could try to replace that as best we can. But I mean, unless we're using autologous fat transfer, and I mean, that has to be like pretty similar fat too that's replaced. But hyaluronic acid biostimulators are not going to cut it. That's my recommendation. And the next chart is just kind of showing a bit more about these specific things that we can do. So we can go into this at a different talk, but we can go into the different types of biostimulators, radiofrequency microneedling. And the other point I shall make, it's reminding me about radiofrequency microneedling for the body. That's something I would do, because if you're losing a lot of weight, you're probably going to get some skin laxity. If you're young, you have enough collagen in your skin that it's going to kind of bounce back pretty quickly. But as we get a little older, we have less collagen. If you lose weight pretty quickly, you're going to get some skin laxity. So find your best dermatologist with a radiofrequency microneedling device, and I would definitely partake in that. That's it for the GLP agonists, and keep watching for more of our Dermatometabolic series. And thank you everyone for supporting the Future of Dermatology podcast. And if you have questions, comments, if you have anything else that you want us to talk about within this series, shoot us a comment. Thanks again.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.